Good morning. So, Mrs. Asdash will be talking about immunosuppression. Thank you very much. She's been here for about 3 years with us. And I think it's an important topic because a lot of our cases are transplant patients. So, thank you very much for preparing this talk.
Thank you, Dr. Duruzman, for your great support throughout the preparation of this presentation. And good morning, everybody. Welcome to our today's morning lecture on immunosuppression. Before I start to tell you about the immunosuppressive agents that we use, I would like to give you some information on the history of transplantation. The very first kidney transplantation was done in the early 1930s in Kiev, where the recipient of the kidney transplantation survived for totally 4 days, and then he passed away due to an acute rejection. Then around 20 years later, a mother donated her kidney to her son. Her son actually lived a little bit longer, but also died due to an acute rejection. But here in this picture in 1954, to be very exact, one day before Christmas Eve, so on the 23rd of December in 1954, Dr. Joseph Murray and his team did the first successful kidney transplantation from one brother to his brother. But this was also without immunosuppression at that time. So why was it successful? The question is actually to be seen on the right-hand side. In the front row, you see the two brothers. I don't know whether you can recognize it. They're twins, and they're not only twins, but they're identical twins. So here it is to be assumed that there was no fear of any immunological risk situation. And that's why this transplantation was successful, and the recipient lived for 8 years with that kidney. Kidney transplantation generally transplantation has evolved throughout the years. Here in this historic picture, you see the first kidney transplant recipient group from the USZ. And maybe I just zoom in a little bit closer to that picture. You can see the faces of all of the recipients. They look pretty alike. They have this roundish face, a little bit swollen. And from this picture, you might assume the immunosuppressive regimen that was administered, and that was high dose of corticosteroids. But also throughout the years, the immunosuppressive regimen has changed and enabled, let me say, a very good quality of life. You see two examples of people who received a kidney transplantation and are professional sportsmen. In this graph, you see the evolvement of kidney transplantation at the USZ. And where the arrow is, you see the beginning of the immunosuppressive agent with cyclosporin A, which is a calcineurin inhibitor, but I will come to that in a minute. It was introduced in around the 70s and was considered as a breakthrough in preventing rejection and actually opened a whole new era in the transplant surgery. Let me say in 1986 alone in the USA, nearly 9,000 kidney transplantations were performed, and they had a greater than 85% survival rate in the first year. So when we talk about liver transplantation, it is important to know that it is the second most performed transplantation after kidney transplantation. The first, and in association to liver transplantation, you have to know the name of Thomas Starzel, who did the first liver transplantation in 1963 in the US. He did the liver transplantation on a child who survived for around 4 days. But for around 4 years later, he did that again, liver transplantation to a child, and that child lived for around 400 days. So here, exactly, you see the first successful liver transplantation. And when a cyclosporin was introduced, it also started a great success curve in the field of liver transplantation as well, because cyclosporin, on the one hand, decreased the frequency of acute rejection and also increased the graft survival, which is actually why the whole transplantation story from then on went off like a rocket. So when we talk about immunosuppressive agents, which kind of immunosuppressive agents do we use? There are a lot of immunosuppressive agents that exist, but I will focus on those 4 groups that we use here in the USZ. So let's start with the calcineurin inhibitors. Cyclosporin A is a calcineurin inhibitor, and that binds to the cytosolic protein cyclophilin, which is an immunophilin. And this complex of cyclosporin and cyclophilin inhibits the phosphatase calcineurin. And calcineurin, under normal circumstances, activates transcription factors that induce the synthesis of interleukins, of interleukin 2 to be very exact, in the T cells. And due to the inhibition of these interleukin 2, we find a reduced function of effector T cells. So this is why the cell-mediated immunity is blocked. As I said, cyclosporin was a breakthrough at that time. Why? Because it did a prevention of acute rejection in more than 50% of the cases. But around 10 years later, tacrolimus was introduced. So tacrolimus actually works very similar. It binds to the immunophilin FKBP, and I'm sure you all remember that. And this complex also binds to the calcineurin and causes an inhibition of the enzyme activity. But also additionally, in general, to this process, the inhibition of the cellular immune reaction, interleukin is also needed to activate B cells to produce antibodies. So not only the cell-mediated immunity, but also the humoral immunity is blocked here. So if they work pretty alike, why should we actually use tacrolimus instead of cyclosporin A? And the question is easy to be answered because the immunosuppressive potency of tacrolimus is way higher than that of cyclosporin A. So following the introduction of tacrolimus in the immunosuppressive protocols, the rate of acute rejection fell progressively to 20%, and that of chronic rejection fell to 5%. That was also shown in the study published in The Lancet. This study involved around 560 patients in 50 European centers in the 1990s, and they compared around 280 patients after transplantation, receiving one group receiving tacrolimus and the other group receiving cyclosporin A. Here you can say that the baseline characteristics were very similar and comparable, and the primary outpoint was the proportion of patients with biopsy-proven acute rejection. And the results here showed that the rate of biopsy-confirmed acute rejection was significantly lower in the group of tacrolimus than with cyclosporin A. It's around 20 versus 37%. And also the biopsy-confirmed corticosteroid-resistant acute rejections was also significantly lower with the group of tacrolimus, who was given tacrolimus. So here it was 9 versus 21%. So you can say that tacrolimus was significantly more effective than cyclosporin. But if it's so effective and if it's so well established in the history of immunosuppression, why don't we use calcineurin inhibitors as a single drug method in immunosuppression? It is because of the side effects. And I'm sure that you know maybe one or two side effects that calcineurin inhibitors cause.
It is nephrotoxic?
Exactly. It is neurotoxic, it's nephrotoxic, and it causes hypotension. And that is because the calcineurin inhibitors cause a vasoconstriction in the vessels, in the glomerulum, and reduce the renal blood flow and subsequently the GFR. So the next group I would like to introduce to you are the anti-metabolites. On the one hand, we have Cellcept, and you also heard of Myfortic. Generally speaking, the anti-metabolites like mycophenolic acids interfere with the synthesis of nucleic acids. So mycophenolate mofetil, abbreviated MMF, is a prodrug of mycophenolic acid, and it is an inhibitor of the inosine monophosphate dehydrogenase. This is also an enzyme that is used very importantly, in the de novo synthesis of purine, or generally of guanosine nucleotides that are necessary in the lymphocyte activation. And the inhibition of this enzyme particularly affects the lymphocytes since they rely almost exclusively on the de novo synthesis. And in contrast to that, many other cell types use the other pathway of purine nucleotide salvage. So that's the reason why the use of mycophenolic acid leads to a relatively selective inhibition of the DNA replication in T and B cells. The main side effects are leukopenia or bone marrow suppression in general and abdominal pain, particularly diarrhea. I'm sure you all heard of that. It affects around 20% of the patients, but it often resolves when we do a reduction of the dose. So nevertheless, it is widely used in the field of immunosuppression, mainly in association with the calcineurin inhibitors. Then as a third group, we have the antibodies. We have monoclonal antibodies like Simulec, basiliximab, and the polyclonal antibodies like grafalon or thymoglobulin. So let's start with the anti-IL-2 antibodies, which is basiliximab. As a monoclonal antibody, it inhibits the interleukin-2 receptor on the surface of the T cells and causes an inhibition of the cytokine release. And this leads to subsequently lower proliferation of the lymphocytes and expansion of activated lymphocytes in the initial cascade of an acute rejection. And for this reason, the antibodies should be given during the first hours or during the first period, as they're not effective as soon as an acute rejection is established. And because they're non-nephrotoxic, I think it's also important for us to know, because they're non-nephrotoxic, they are used particularly after liver transplantation in patients with renal failure. The other group is like grafalon and thymoglobulin. These are anti-thymocyte globulins. And this is an antibody that is effective in prevention and also in the treatment of rejection. These are polyclonal antibodies, and they're from rabbits or from horses that were immunized with human T cells. So what they do, they specifically bind to those human T cells and B lymphocytes and simply destroy them by opsonization and lysis. And due to severe complications such as lymphoma or opportunistic infections, the duration of the administration has been reduced. And nowadays we administer it for around 5 days. It's non-nephrotoxic and can be used in patients with renal failure. So the last group are the glucocorticosteroids. I will keep that short. It is introduced as one of the very first immunosuppressive agents in the 60s. It suppresses the cell-mediated immunity by inhibiting genes that code for interleukin-2 and TNF-alpha. And as you remember, a smaller cytokine production causes a reduced T-cell proliferation. The widespread use of steroids in transplantation generally reflects the many potent actions, but it leads to a group of severe complications and side effects and toxicities. And I'm sure you also know maybe one or two of those.
Either morbus Cushing or a disturbance of the glucose metabolism.
Exactly. Thank you. It can cause numerous side effects such as diabetes, morbus Cushing, as you said, infection, poor wound healing, and the list goes on and on and on. So we talked about the different groups of immunosuppression, but let's talk about who actually needs immunosuppression after the transplantation. And for that, I would like to give you 3 different situations. We have to differentiate between those situations. So first of all, we have the situation where we have a low immunological risk situation, for example, in patients having their first transplantation, or even, let me say, immediate immunological risk situations in patients, for example, who have a retransplantation. But in this first situation, you expect the graft to function properly. Secondly, we have the group with not a moderate, but now a high immunological risk situation, or when you have DSA, so the presence of donor-specific antibodies, but still you have here a DBD, so you assume that the function will be sufficient enough after the transplantation. And the third group is when you expect a delayed graft function. This can be, or any kind of risk situation after the surgery that is from the donor, him or herself. So either the donor is older than 65, you have a so-called acute kidney insufficiency kidney, or you have a DCD organ. So here in this situation, you expect a delayed graft function. So again, to summarize that, the first 2 situations are risk situations that are recipient related, And the third situation is donor-related. So how we induce and maintain the immunosuppression. Imagine the first situation, so a patient having his or her first or maybe retransplantation, but a maximum medium immunological risk situation. We start broad and extensively with the induction therapy that consists of ProGraf, so calcineurin inhibitor, Cellcept, the antimetabolites, the glucocorticosteroids, high-dose glucocorticosteroids, IV, and Grafalon, which are the antibodies. And then we continue a little bit more relaxed in the maintenance therapy without the antibodies. In case of a high immunological risk situation, we administer Grafalon for a longer period of time. Remember, when you have the DSA, the donor-specific antibodies, you would like to administer antibodies that work against that for a longer period of time. And if there is a donor-related risk situation where the delayed graft function is to be assumed, it is important not to stress let me say in this case, for example, the kidney any further by administering ProGraf that has nephrotoxic side effects. So we do not administer ProGraf because of its nephrotoxicity. We also administer Grafalon for a longer period of time. And here we start the calcineurin inhibitors that have these nephrotoxic effect, maybe a little bit more postponed, but within the first week after transplantation. And we increase the doses very, very gently until the trough level is reached. And the trough level, maybe for one of you who have not heard of this term, the trough level is the level of the whole blood that is measured right before the patient would take the next medication of his immunosuppression. So the lowest concentration of, for example, tacrolimus. This is the trough level. So why is it important to know about immunosuppression for surgeons? Not only for us, because we're a center that do a lot of transplantation, but actually for any kind of surgeon, it is important to know about immunocompromised patients and surgery in general. And this is because immunocompromised patients have a much higher risk for poor wound healing or infection that can lead to sepsis and even to death. So what does the data actually recommend us? When to stop the immunosuppression right before surgery? When should we actually stop? Or when should we proceed again? When should we start again after the surgery has taken place? The answer is that there is actually no answer yet. There are hardly any randomized controlled trials. Why is that so? Because the groups are way too heterogeneous. You cannot compare a kidney transplanted patient with a liver transplanted patient or even with a lung transplanted patient. And on the other hand, the surgery, the groups are also too heterogeneous. Here, for example, you cannot compare an appendectomy with a cecum resection after a cecum perforation. So the level of evidence is not sufficient enough. To have that answer for this question, it is needed that we do more randomized controlled trials on this topic. So to summarize this presentation, I would like you to remember that immunosuppression caused a great success story in the field of transplantation. But within the last 2 decades, there has not been a lot of change. And we have a very heterogeneous group of immunosuppressive agents. We here at the USZ, we do a combination of different immunosuppressive drugs. Why? There are 2 reasons. First of all, we would like to maximize the immunosuppressive effect. So you have a problem and you try to tackle the problem from different perspectives. And you always have to remember that these immunosuppressive agents have a lot of side effects that need to be prevented. So that's why when we use a combination of different immunosuppressive drugs, we can minimize the side effects because we can keep the doses of each and one of these immunosuppressive agents at the most possible lowest dose. Exactly, that was it from my side. Thank you very much for your attention.
Well, Adak, thank you very much. I think this is important. The last 2 points is important, is to minimize the side effects because the side effects are here. And patients are afraid of these side effects. And even though they do have side effects of these therapy and treatment, the results of transplantation, if it's kidney or liver transplantation, it's great. Does anyone have a question?
So thanks, Adak, for this nice overview. The point which I want to make is, if you go in a transplant center and you ask the protocol, you will get every time a different answer. And it's important that you all understand, despite of 40 years of very large research, we don't understand the basic mechanism. We don't understand immunosuppression. We don't understand the rejection mechanism, because there are huge differences between organs. In liver transplantation, for example, we have usually a mono treatment with low dose tacrolimus. We don't see T-cell mediated rejections. If we see any, we treat it successfully. We don't care about DSA. We don't care about HLA matching. Complete different in kidneys. And I think we need to understand that we come too late with immunosuppressive treatment, because what we usually forget is the effect of the organ, because we don't transplant healthy organs. That's a misunderstanding. We transplant organs from people which died, and that has a much higher effect than we believe. And I think we need to treat the organs, and then we will have a different consequence on rejection, on inflammation, and so we start usually when the patient is going to be transplanted, and that is probably too late. Yeah, it's important that you understand immunosuppressive treatment is in every center different, and that the reason for that is that we don't understand it.
I think this is a very important point, but at the same time, we have very long-term results and very good long-term results. And every study you want to do, it's very difficult to find an endpoint on your study. And this is why we don't have much data, because everything, if you want to change something, you'll have the difference after 15 or 20 years. If we're talking about kidney transplantation, we don't have primary endpoints. And this is a whole different story, but a very important thing to notice too, because most of our patients do have a chronic rejection. And this chronic rejection, we don't know when it starts and how to treat it. Any other questions? Okay, well, thank you very much.